Good evening. I'm Kelly Gear-Ripken, National Chair of A Woman's Journey. On behalf of Johns Hopkins Medicine's A Woman's Journey, thank you for joining us this evening for our monthly webcast series, Conversations That Matter. A Woman's Journey strives to improve your well-being through health education. Tonight, we are joined by orthopedic surgeon, Dr. Dawn LaPorte, a professor of orthopedic surgery at the Johns Hopkins University School of Medicine, whose areas of clinical expertise are hand and wrist injuries, including ligament injuries, avascular necrosis, arthritis, nerve compression, carpal tunnel, and other syndromes. So please use the Q&A on your screen to ask questions to Dr. LaPorte, who will respond during the last 15 minutes of tonight's conversation. Our webcast will conclude at 8 p.m. this evening. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for the production assistance, and you can visit their website for additional lectures and courses throughout the year. And now I am pleased to welcome Dr. LaPorte. Dr. LaPorte?
Thank you very much. It's an honor to be here with all of you tonight and to get to talk about hand surgery. Let's see.
Pleasure to have you. Thank you.
Thank you. One of the things that drew me to hand surgery in the first place is the importance that the hand plays to us all as individuals. Hands let us play music and create art and enjoy sports and share our affections, like, for example, holding hands or holding a baby or holding on to our loved ones. There are a lot of different varieties of hand problems, and there are some that are more common in women, which we'll focus on tonight. Hand problems can include very common conditions like carpal tunnel syndrome, arthritis, tendonitis, and fractures of the hand or wrist, as well as trigger fingers, and the most common tumor in the hand, which is a ganglion cyst. And then there are other more uncommon conditions or tumors or trauma. The hand has very complex anatomy. There are 27 bones in the hand, and there are 3 tendons in each finger, and 3 primary nerves that innervate the hand to provide sensation and motor, and 2 main arteries. And hand injuries represent up to 10% of all emergency department visits. So they're a large cause of missed work days and lost productivity. And carpal tunnel syndrome can affect up to 10% of the population. There are a number of myths about hand injuries or hand conditions. One, that you can't get carpal tunnel syndrome if you don't type a lot. Certainly repetitive motion and doing a lot of keyboarding puts individuals at risk for carpal tunnel syndrome, but you also can get carpal tunnel if you never touch a keyboard. It can affect, like I said, up to 10% of the population. Cracking your knuckles has been rumored to cause arthritis, but it does not. You can get tennis elbow, even if you don't play tennis. And if you have a cyst on your wrist, like this individual in the picture, you should not hit it with a book. There are many safer, better treatments. So what hand conditions are more common in women? First, and probably affecting the most of all, would be carpal tunnel syndrome. Trigger finger would be a close second. And then thumb arthritis, primarily at the base of the thumb, which is the second most common place to get arthritis, affects women 10 to 15 times more frequently than men. And wrist fractures are more common in women because of the risk of fragility fractures, which are associated with osteoporosis. So after menopause, wrist fractures affect women much more than men. So I was going to present a couple of examples of some of these conditions that affect women more than men and talk about some of the presenting symptoms, some of the different treatment options, and some of the future directions and research that's going on in these conditions. So our first example patient is a 65-year-old woman who presents to my office with complaints of right more than left hand pain, numbness, and tingling. Her symptoms have increased over the past 6 months, and she occasionally will drop something from her hand, like silverware, and has difficulty fastening buttons or doing her jewelry clasps. She also will sometimes wake up at night and have to shake out her hand because it's painful or numb. So what does this patient most likely have? She most likely has carpal tunnel syndrome. And carpal tunnel syndrome is the most common compression neuropathy. It's caused by a decreased amount of space for the median nerve at the wrist. And that's the nerve that gives feeling to the thumb, index, and middle finger, and the thumb half of the ring finger. Carpal tunnel can affect both hands and is frequently bilateral, affecting both hands in up to 60% of people. And these patients typically will present with complaints of numbness and tingling, typically in the thumb through middle finger, dropping objects, and waking up at night because of pain and or numbness. The numbness, again, affects primarily the thumb side of the hand because the small finger is innervated by a different nerve, the ulnar nerve. So are there risk factors that put people more at risk for carpal tunnel other than doing a lot of keyboarding? Yes, women are affected 3 times as commonly as men, and patients who have diabetes or thyroid disorders are at increased risk for carpal tunnel. Obesity puts patients at greater risk for carpal tunnel, and pregnancy, because of increased fluid retention, puts patients at increased risk for carpal tunnel syndrome. More advanced carpal tunnel, so there's mild, moderate, and more severe forms of this. So the more advanced versions, the patient will have constant tingling. Their fingers are always feeling like they're asleep. They'll have waking up from sleep multiple times a night, and they may lose some of the muscle at the base of their thumb, which causes weakness. The diagnosis typically can be made by symptoms. If somebody has numbness and tingling in the thumb, index, and middle finger, and or that nighttime waking, typically we can say that's going to be carpal tunnel syndrome. But the gold standard, the most objective way to make the diagnosis, is something called a nerve conduction study. And this is performed by either a neurologist or a physiatrist, and they give little electric shocks and measure how fast the nerve carries a message. And so it's an objective measurement, and it's compared to standards, and can say that you do or don't have a pinched nerve, and how severe is it, and is there more than one nerve involved. The first line of treatment for carpal tunnel syndrome is a brace that you wear when you're sleeping, and it keeps you from bending your wrist. And the reason that's effective is the nerve runs in a straight line across the wrist, and people tend to sleep in a fetal position, curled up, and that puts increased pressure on the nerve. And so the brace prevents the patient from flexing or bending the wrist and takes that pressure off the nerve. And up to 70% of people will have relief just from the nighttime splint. If they have persistent symptoms despite the splinting, a cortisone injection into the carpal tunnel can be helpful. This puts a strong anti-inflammatory around the nerve and decreases the pressure on the nerve, and most of the time will relieve symptoms, but only about 20% of the time will it be a permanent correction. The majority of patients will get better, but then their symptoms will come back. And if their symptoms come back despite nighttime splinting and an injection, or in a patient who has severe carpal tunnel when they first present, the recommended treatment is surgery. And in the surgery, we release the band of tissue overlying the nerve. It's called the transverse carpal ligament. And that basically opens up the roof of the carpal canal and takes the pressure off the nerve and gives it more room. And once the pressure is off the nerve, the pain gets better really pretty quickly, because that's truly caused from the pressure. And the numbness gradually improves because the nerve takes some time to recover. What happens if you don't take care of your carpal tunnel syndrome, if you ignore it, it's not likely to go away on its own. It's likely to progress and get worse with time. And it can get to the point where you lose that muscle at the base of your thumb, which then can result in inability to bring your thumb across to pinch and pick up objects. And once that muscle is lost, even with surgery, we can't give that back. And so that's why it's important not to ignore symptoms of carpal tunnel syndrome and not to let it get to that point. Again, a large majority of patients will get better just with nighttime splinting. So usually that's a good place to start. But if it gets to the point of needing the carpal tunnel release surgery, the surgery has a 90% good and excellent result rate, which is very promising. So again, you can get carpal tunnel even if you don't do a lot of typing or repetitive motion. It's important to treat early so that you don't get to the point where muscle is lost and cannot be restored. And carpal tunnel syndrome in pregnancy, which I mentioned briefly, is a little bit different in character because the symptoms typically will resolve after delivery. So we try very hard not to operate on carpal tunnel that presents first during pregnancy. Those patients often will get better with splints. If they don't, a corticosteroid injection is safe in pregnancy, and that will usually make the symptoms better until after delivery, when the symptoms should resolve on their own. So you may wonder, why are women more at risk for carpal tunnel than men? Why do many more women than men get carpal tunnel? And this is still an area of research, but there is an association with hormonal changes affecting fluid retention, particularly during pregnancy, and then again in menopause, as well as with rapid changes in hormones, so in estrogen levels. So we see this again frequently in the menopause and postmenopausal time frame. And also, women are more at risk for thyroid disease, and carpal tunnel is more common in patients with thyroid disease. So that plays into the increased risk for women, as well as the association of carpal tunnel with obesity. So if you are an individual who does do a lot of keyboarding, ergonomics is important. Many places of work will have an opportunity for an ergonomic workstation evaluation through HR, and I would strongly encourage that. You want to have a setup where you're able to sit straight with your elbows close at your sides and your forearms essentially straight when you're typing, so you don't have excessive bend in your wrist. A padded wrist support can be helpful. And as simple as it sounds, you also don't want to have a death grip on tools when you're using them. You want to have a light touch and tap gently on your keyboard because that helps diminish some of the component of the repetitive stress. Some of the ergonomic keyboards can be helpful. And a really simple intervention is to make sure that you take breaks. Don't type nonstop for a couple of hours. And there are a number of programs that you can put on your computer that will give you a reminder to take a break at certain intervals. And then you can go get a cup of coffee, or you can answer phone calls, or do something different just to break up that repetitive motion. And that genuinely can be very helpful. What are areas of research with carpal tunnel besides looking at the causes or the risk factors? Nerve conduction studies are very helpful for the diagnosis, but they're an uncomfortable study. And so there's a lot of effort going into looking at the value of ultrasound, evaluating the space available for the nerve. And I feel strongly that once that is validated, that will become the new gold standard. It'll be a lot more comfortable for the patient, most importantly, and it'll be less expensive. There's also been some very good multi-center studies looking at endoscopic, which is a very small incision, and endoscope that goes in to do the surgery for the release, versus an open release, which has an incision and is a slightly longer recovery. The results are have been shown to be pretty comparable. There's a slightly increased risk of nerve injury with endoscopic and a slightly longer return to work after open. And here at Hopkins, we're doing a study looking at ulnar nerve decompression. Ulnar nerve is the second most common compression neuropathy after carpal tunnel. It causes the numbness in the small finger and the small finger side of the ring finger. And we're part of a multi-center study looking at which surgery is the best, just releasing the nerve, which is a slightly quicker recovery, versus transposing or moving the nerve to a better position. So, Moving on to our next patient and next condition. The next patient is a 50-year-old woman who presents with ring finger catching and clicking with associated pain for about 3 months. She says that the pain is worse at night and will occasionally wake her up in the morning with the finger stuck in a bent position, and she may need to use her other hand to unlock it. She denies any recent accident or injury. You can see this is a video. I'm not sure if you're seeing this. The patient's finger is sticking and they have to pop it out. And sometimes the patient will wake up in the morning with the finger stuck in a position like this. So this is what a trigger finger is. A trigger finger is caused by inflammation in the tendon that bends the finger, so on the palm side of the hand. And when you bend your finger, the tendon has to glide under a tunnel. So it's almost like a belt going through a belt loop. If there was a knot on the belt, it would catch on that loop. And that's what's happening with a trigger finger. And trigger fingers are more common in women as well as more common in patients who have diabetes. Trigger fingers can affect any finger, including the thumb, and can affect both hands. And this is an illustration showing a normal caliber of tendon passing under these tunnels in the finger. And this is when there's some inflammation in the tendon, and that's why it catches. And so if this is happening to you or to a friend, or if a patient comes in with this, sometimes patients will start with anti-inflammatory medicine or a splint to keep it from locking, but that is really unlikely to take care of the problem. It may help with the pain, and putting a splint on will keep the finger from locking by keeping it from bending. But when the splint is off, it's still going to lock. And so for trigger fingers, the best initial treatment is a corticosteroid injection. And the reason for that, it puts a strong anti-inflammatory by the enlargement in the tendon, which should then shrink that knot, and then the tendon can move back and forth without catching. And up to 90% of trigger fingers will resolve, go completely away with a cortisone injection. And so that's really effective. However, in up to 50%, the triggering can come back in 6 months or a year. There's an increased risk of it coming back in patients with diabetes. And if it comes back multiple times, then we recommend doing a surgical release of that pulley or the tunnel that the tendon runs under. And this, like carpal tunnel surgery, which I didn't say, these are outpatient surgeries. They can be done with local anesthesia. And there are some restrictions after surgery, some lifting restrictions, but you're back to using your hand pretty normally within a month or 6 weeks, depending on your level of activity. So next, I'm going to talk about a patient who has arthritis. Next patient is a 55-year-old woman who presents with right wrist and base of thumb pain that's been increasing for the past few months, but has been present for more than a year. The patient has increased pain with wringing out a rag or opening a jar, or also holding a newspaper open to read it. She also has noticed a bump or a prominence at the base of her thumb where the thumb meets the wrist. She denies having any accident or injury, no trauma. And the likely diagnosis here is thumb arthritis. The base of the thumb is called the carpometacarpal joint, and that's where the arrow is pointing here. And you can see the prominence that the patient was describing, which is a bump from the base of this bone called the metacarpal, because the joint is no longer congruent. So arthritis is the wearing down of cartilage at the joint. And in this case, the patient has bone rubbing against bone, and that generates pain. And that pain is worse when you're loading the thumb, for example, turning a key or opening a jar. And there are many activities that you need your thumb for. Patients are always amazed that it's very hard to avoid using your thumb. Even when you're just pulling up your pants or pulling on pantyhose, you're loading that joint. And so when the pain is there, it's hard to make that go away by just avoiding things. 1 out of 6 women will have moderate to severe X-ray changes at the base of their thumb, and women are 10 to 15 times more common than men to get this form of arthritis. It's the second most common arthritis in the hand, but probably the single most disabling because of how important the thumb is. There are some risk factors for having this arthritis at the base of the thumb. You may have a family history and there may be a genetic component to this. There is an increased association with obesity, but there are plenty of thin people who have thumb CMC arthritis. There's an increased incidence with increasing age, and particularly in women as they pass through menopause, there's a spike in incidence, and there may be an association with prior injury or trauma. The first line of treatment for this is a splint or a brace that will unload that joint. Ideally, it's a brace that lets you fully move your fingers and the end joint in your thumb so that you can wear it when you're awake and doing things, and you can still use your hand. The splint is much more effective if you wear it when you're awake than at night, like the carpal tunnel brace. Anti-inflammatory medicine can help with this because arthritis is an inflammatory condition. The pain is caused by inflammation at the joint. If patients have persistent pain despite splinting and anti-inflammatory medicine, then a cortisone injection into the joint can be helpful. That puts a strong anti-inflammatory right into the involved joint, so it's very specific and can help relieve symptoms, but usually is time limited. And injections can vary on how long they last in different patients. Sometimes it's as short as a few months. Sometimes it can be more than a year. But when it gets to the point where the injection is no longer helping or no longer lasting more than 3 months, there is a surgery for this, and it's a joint replacement. But unlike hip and knee replacements or shoulder replacements, which have a metal and plastic prosthesis, there's no foreign matter that goes in for this surgery. It's a joint replacement with the patient's own tissue. There are 2 tendons in the wrist that do the same thing. And so you can take one of them without the patient losing any function and replace this, let's see if I can do this, replace the smaller of the 2 bones that are rubbing against each other. You take that one small bone out and put a tendon in its place. And again, it's the patient's own tendon, so there's no foreign matter, and that tendon acts as a cushion. So instead of bone rubbing against bone, which causes inflammation and is painful, you have a bone against a soft compressible tendon, which is not painful, acts as a cushion, and also acts as a support. So once the patient has recovered from this surgery, they should be able to get back to whatever they enjoy doing. There's no long-term restriction with this. And because there are no metal or plastic components, there is not an implant that can wear out. And so conceptually, this should last forever. It should be a surgery that does not need to be revised down the road. A big question, why do women get this base of thumb arthritis more frequently than men? This is an area of research, but this also appears to be associated with hormones, partially with estrogen, which helps to decrease inflammation. But also there's a hormone called relaxin, which loosens ligaments. And the thought is that women have more relaxin, and that helps to, or that contributes to stretching out the ligament that supports the palmar part of this joint. And so there's more motion in a woman's thumb CMC joint than in a men's, which predisposes them to a greater risk of arthritis. Currently, there's no interventions that are targeting the hormone role in this, but I think that's an area for future investigation. And there's a study currently being done at Johns Hopkins where our plastic surgery hand surgeons are doing a procedure called a denervation. So they're cutting just the nerves that innervate that joint. So nerves that cause pain at the joint, but don't account for motor or feeling. So you don't lose any function, but it should help to relieve the pain without the joint replacement surgery. And we're comparing those with our patients in orthopedics who are having the joint replacement surgery. And so both of those are actually options now for real patients. And we're working on collecting the data to show if the outcomes are similar. One other thing that I thought was really important to mention is wrist fractures. So wrist fractures are the second most common fracture in adults after clavicle or collarbone fractures, and are most commonly due to a fall. But women are more at risk, particularly postmenopausal, for wrist fractures, primarily because of what we call fragility fractures, because of the association with osteoporosis. So if you look at the data, women have wrist fractures 4 times more frequently than men. And there's a particularly big jump in increase in that risk in the perimenopausal and early postmenopausal years. So if you are a woman who had a fall from a standing height, or what we call a low energy fall, and you break your wrist, that may be the first indicator that you have osteoporosis or low bone density, and may be an important predictor of spine and hip fractures. And so any woman who has a low energy wrist fracture should be evaluated for bone density and considered for intervention for that. That's important to pay attention to as well. And I am open to answering any questions about any of that. I appreciate your all being here.
Thank you, Dr. LaPorte. Wow, lots of wonderful information. So before we get started with our viewers' questions, I'd like to ask, why are many of these injuries, I think you've mentioned this over and over again, but we'll just say it one more time, why these injuries appear, to occur more frequently in women? It seems to be due to loss of estrogen, or, through menopause and such. Any other particular reasons, or just mainly that?
So that's probably the main reason in a lot of these, the loss of estrogen resulting in increased inflammation. But also on the carpal tunnel side of things, there's that increased association with thyroid disease and with obesity, which unfortunately both affect women more than men at this point. And so that puts women at a higher risk as well. And there may be a component of that repetitive motion, that women are more frequently in repetitive motion type of work. And that may put them at greater risk, both for carpal tunnel and for different forms of tendonitis.
So for any of those that you mentioned, what would be the best thing to help to prevent that? With exercising, certain types of exercises, foods that you eat, or none of the above?
Good. I think that's a good question. And there's definitely more work to be done in that area, but maintaining supple joints, so stretching when either before or after you exercise, is really important because that helps prevent nerve compression and can help prevent tendonitis as well, or help decrease the risk of that. Taking breaks when you're doing repetitive tasks. And that's not just keyboarding. If you're, painting a room in your house, don't do it nonstop. If you're ripping up tile, if you're gardening, people lose track of time. Try to make yourself take a break intermittently to break up that repetitiveness, because again, that predisposes to not only nerve compression, but also tendonitis, often is an overuse type of injury.
So would you say then that it's pretty difficult to not somehow end up with some type of either arthritis or carpal tunnel syndrome or something? It sounds like in particular arthritis as we get older. It seems that no matter kind of what we do, watching what we eat, don't be repetitive in certain things, and exercising, stretching and stuff. But it sounds like it's sort of a natural aging process, or not really.
Unfortunately, yes, I would agree with that. I think the vast majority of people will at some point have at least an element of arthritis, and it will affect some people certainly more than others. But I do think with our, fortunately aging population, it is inevitable that that will play a role.
Right. So, and I would imagine then the history, your family history as well, taking a good look at that and seeing, maybe what your parents have or grandparents or siblings or.
Yes, genetics definitely predisposes people to at least arthritis.
Right. Okay. All right. Well, thank you. Let's get started then with our audience. And I'm going to start with a question from Laura. And she asks, is there a cream that really works to stop the pain of arthritis in your fingers?
Thank you, Laura. That's a great question. And there are the over-the-counter, like an icy hot or a freeze, but what I like to recommend is something called Voltaren gel, or diclofenac is the generic form of it. And it's a topical anti-inflammatory. So it truly does have anti-inflammatory components. It is a prescription, but I think you can get it over the counter now as well. And it has a much lower risk profile than taking oral anti-inflammatories if you're concerned about GI side effects or if you're on patients who are on a blood thinner. So the topical diclofenac you can put on any affected joint up to 3 times a day based on symptoms. It doesn't burn your eyes like the icy hot type products do. And I think they're, in studies it has been shown to have impact for small joints in the hand, but also in the wrist and in bigger joints as well.
Mm-hmm. So Dr. LaPorte, are those over the counter or a prescription?
It's both. And the reason why some patients like to get it as a prescription is sometimes it's less expensive.
Mm-hmm. Okay, great. Thank you. Our next question is from Carol. She would like to know, how long is recovery following repair of the trigger finger and carpal tunnel? So both surgeries.
Sure.
Mm-hmm.
Thanks. And you can have both of those surgeries together. So, if a patient comes in with carpal tunnel and a trigger finger in the same hand, we would usually recommend fixing or correcting them at the same time, because then it's one anesthesia and one recovery period. Both of those are outpatient surgeries and can be done with local anesthesia. So you go home the same day. Typically, we ask the patient to keep the hand dry, so to cover it up for showers for a week, just to allow for appropriate wound healing. And we usually limit lifting to no more than a few pounds for about a month. And so I would say you would have lifting restrictions for a month. And then if you do light demand work, meaning you could still it could still be very demanding work, but that you don't have to do a whole lot of lifting, you can be back keyboarding as soon, truly you could be back as soon as a week or 2 later. You're just not going to be as fast as normal. And so usually I tell patients it's 4 to 6 weeks. That being said, we do have patients that go back to work the next week and just work within their comfort level. So it's a little different for everyone, but I think the standard would be that you'd have some lifting restriction for a month and you wouldn't be typing at your normal speed for at least a month.
So Dr. LaPorte, would you go to physical therapy after that, or does your physician just give you exercises to do?
So that's a little different based on each patient. I think patients are usually a little bit stiff after both of those surgeries, because there's always swelling after a surgery and you're working around tendons. A trigger finger, you're directly at the tendon, and there are 9 tendons that run in the carpal tunnel with the median nerve. And so I usually send the patient to a therapy visit the day they get their stitches out. And the therapist will give them something for the scar to wear at night to help the scar heal nicer, quicker, and some exercises. And sometimes patients will go 2 times a week for a few weeks to help them get their motion back. And sometimes they'll go to just that one visit and do home exercises.
Sure. Great. Thank you. Our next question is from Amy. Is there anything I can do as a postmenopausal woman to improve my hand strength and stability?
Good question. So using your hand in your normal daily activities maintains the mobility. However, doing some exercises is really helpful for strengthening, and the muscles that motor your hand are based primarily in the forearm. And so light weight bearing exercises can be very helpful with that. If you feel that you have weakness in pinch or grip, we often will send patients for a visit or two with hand therapy, and they will give exercises that you can do with putty. So putty is like grated Play-Doh. And to work the small muscles in the hand, that's probably the most effective way. There are pinch and grip strengtheners that you can buy through Amazon or through other companies like that. And those can be effective. But if you have concern that you're losing some pinch or grip strength, going to a visit or two with hand therapy, they'll give you a good home program with putty, I think is most effective.
Mm-hmm. Thank you. Our next question is from Samantha, and you did touch on this in your presentation, but if you wouldn't mind just kind of giving the 1, 2, 3 of how do you diagnose carpal tunnel syndrome? Again, just kind of briefly.
Yeah, sure. So the classic symptoms of carpal tunnel syndrome would be numbness and tingling, like you feel like your hand's falling asleep, primarily in the thumb, index, and middle finger, and maybe half of the ring finger. Waking up at night and having to shake out the hand. And so sometimes just based on those symptoms, we can say you probably have carpal tunnel syndrome. In the clinic, so if you come into the office, there are 2 tests that we'll do, just sitting across from you. We'll tap on the palmar aspect of your wrist. And if tapping there causes numbness and tingling or tingling into your thumb, index, and middle finger, that's considered a positive indicator of carpal tunnel. And the other test is having the patient bend the wrist about 90 degrees, like that. And that puts increased pressure on the nerve. And that's considered a positive test if holding the wrist in that position for about 30 seconds also causes tingling in the thumb, index, and middle finger. And then the diagnostic test, like comparable to an X-ray, because X-ray doesn't show carpal tunnel, is something called a nerve conduction test or electrodiagnostic study. And those are currently performed by either a neurologist or a physiatrist, which is a physical medicine and rehabilitation specialist. And so they're both MDs, and they perform this study by giving little electric shocks and measuring how fast the nerve carries a message over a given space. And so they can objectively tell if there's compression at the carpal tunnel, or if it's somewhere else on the forearm or a different nerve. And that's what we call the gold standard for diagnosis. And hopefully moving forward in the future, at some point, an ultrasound exam to assess the space available for the median nerve in the carpal tunnel will be another diagnostic option, but that's not yet been validated.
Mm-hmm. And Dr. LaPorte, I think you did mention too that left untreated, they don't really get better. Is that correct? You need to take care of them.
That's correct. Other than in pregnancy, where it should go away after you deliver, all other presentations of carpal tunnel, you really should get it treated.
Yep, because they're just not going to go away. Right. Yeah.
Right. Yep. And you can get to a point where you lose muscle, and then we can't help bring that back.
Mm-hmm. So it's a good thing to get on right away. At least start in the easy parts of, maybe putting that splint on your hand and on your wrist and see what happens. So our next question was back to an exercise question. This is from Peggy, and she would like to know if using hand weights for exercise, will it help with arthritis, or does that actually make it worse?
So that's a very good question. And the answer can actually go in both directions, which doesn't sound like that makes sense. Maintaining your strength and mobility is helpful to protect the joint. But if you have arthritis and you have a flare, then you want to rest the joint. So when arthritis is flared, so when it's particularly painful, you really want to hold that joint still, which is why we often will treat with a splint or activity modification. So in that situation where your joint is red and very tender, you don't want to be lifting weights and stressing it more. But on the day-to-day basis, if your baseline is a little bit of pain, if you do the wrong thing, continuing to do some lightweight bearing exercises is helpful.
Mm-hmm. So also things like yoga, which is pretty popular, Pilates, things like that. But obviously, if things hurt, don't do them.
Give it a break, right?
I think some people think if you keep doing it, okay, it'll eventually, this is going to go away because they think you're strengthening it, but actually you're probably doing more damage, it sounds like.
Right. But you mentioned yoga and yoga and bar. Those are really great ways to maintain flexibility, which is protective for your joints. So that can be very helpful if you enjoy doing it.
Yeah, great. So our next question is from Maria, and she'd like to know, does the loss of estrogen following menopause increase the likelihood of hand issues, which I know we've talked about loss of estrogen. Is that always the case?
So I guess I would say the loss of estrogen has been tied to increasing inflammation. And so it would put individuals at increased risk for hand problems or for any problems associated with inflammation, which would include tendonitis, nerve compression, and arthritis, but it doesn't affect everybody. So I think everyone has that increased risk after menopause with that change in hormonal environment if you're not taking hormone replacement, but it doesn't mean 100% that you will get any one of these conditions.
Mm-hmm. Thank you. And Jane would like to know, what kind of splint is used for CMC arthritis, and is it available over the counter?
Yes, good question. For CMC arthritis, it's something called a thumb keeper splint. And so it's a thumb splint that holds the base of the thumb, but should let you move the end joint of your thumb. And it should let you move your wrist as well. And you can pick that up at a pharmacy that has durable medical goods that sell splints or online. And if you have a hard time finding a splint, if you have a physical therapy facility nearby, they can often help you order it as well. So basically that splint should hold the base of your thumb, but let you move all of your fingers and move the tip of your thumb.
Mm-hmm. So also on that note, because that was about wearing that with arthritis, but you also suggested wearing a splint at night for carpal tunnel. What about during the day? Wearing, actually for any of these, for arthritis or carpal tunnel, but wearing any of these splints, would you wear them during the day, or would you take them off and use heat or ice, or all of the above?
Right, all good questions. So for tendonitis and arthritis, the splint is actually more helpful if you can wear it during the day when you're doing things, because that's when you're putting increased strain on the tendon or on the joint. And that's why we try to develop these splints so that you can function with it on, because for thumb arthritis or for tendonitis, they're much more effective if you wear them when you're awake. And they're removable, so you can take them off when you need to. If you have an event or if you're cooking and you're in and out of water, they're a bit of a nuisance, but those are more effective daytime. Whereas for carpal tunnel syndrome, the brace is actually more effective at nighttime, and we recommend people wear it when they're sleeping to prevent being curled up and putting increased pressure on the nerve. That said, there are patients with carpal tunnel who are really bothered by their carpal tunnel when they're driving a lot or when they're keyboarding, and the brace can definitely be helpful when you're awake then too. So when you're doing those provocative activities. sometimes people will question if they wear a brace too much, will their hand get weak? Will they lose muscle? And we have not found that to be the case because you're still using your fingers, you're still using parts of your hand. And so this is, it's a treatment, and there's, I don't think there's a negative as far as muscle loss with the brace. And you asked about cold and heat, and both of those can be really effective for inflammation. For an acute injury, so, you know, for example, the wrist fracture, or if you have a sudden onset of tendonitis and pain, ice is usually most helpful for a you know, acute injury for the first few days. But for arthritis and carpal tunnel, heat can be helpful too. Heat actually decreases inflammation, immersing in heat, so immersing your hand in warm water, or even many patients with arthritis will say their hands are very stiff when they get up in the morning until they take a warm shower. And so finding what works best for you can be very helpful. Patients who have finger arthritis often will get home paraffin baths, like you may have seen in a nail salon, and that heated wax really helps to pull out inflammation. It's temporary, but it can help you get going at the beginning of the day, and you know, make you a lot more comfortable.
Sure. Great. Thank you very much. So our next question is from Teresa, and she would like to know, are there risks involved in getting cortisone shots? And, you know, how many do you really do until you finally get to the point that maybe perhaps you really should be going the surgery route?
Yeah, another excellent question. So there's a low volume of cortisone that's given in these hand injections because hand joints are small, and the spaces in the hand are small. So it's less than you would get in a hip or a knee, for example. However, for patients who have diabetes, there is a risk of a transient, a temporary increase in your blood sugar from the little bit of that steroid that gets into your system. And so that's important to be aware of. It wouldn't mean you shouldn't have the injection, but it would mean that you should check your blood glucose after having the injection. There's also a risk of hypopigmentation, so loss of some skin pigment, because a lot of these injections may be pretty superficial. The tendons are pretty close to the skin. And so in less than 10%, but certainly in some patients, they'll get a lighter patch of skin where they had the cortisone injection. So those would be probably the two risks that I would mention with getting the injection. But what about the limits? If you have too many corticosteroid injections in one space, and I'll tell you what I think is too many, it can weaken the tendon. So for trigger fingers, we strongly recommend no more than 3 injections in any single trigger finger in a lifetime. So if you have improvement, but then your trigger finger comes back, and that happens 3 times, then it should be an absolute recommendation for surgery. So no more than 3 in any given finger for a tendon problem, because the cortisone over time can weaken that tendon. If it's a shot given in a different finger, it's not going to have an impact on that tendon in the other hand or in a different finger. So that's specific to the digit. And then for arthritis, so kind of 2 different rules. One for tendons, which I would say is no more than 3.
Excuse me, Dr. LaPorte, would you say 3 total ever? Is that what you mean? Or do you mean
3 total ever in that one anatomic area. However, for arthritis, the downside of too many injections is that it can wear the cartilage, which is what arthritis is. And so if the next step after having cortisone injections is something like a joint replacement, like we're talking about in the thumb, usually there's not a hard and fast limit, because if you have a 4th injection and it wears your cartilage, the next option is the same as if you required the patient to have surgery after no more than 3, if that makes sense. And so for arthritis, we often say if it's giving good relief for 6 to 12 months, you can keep going until it gets to a point where the injection's not having the same benefit or it's not lasting as long. So a different rule if it's a arthritis or if it's a tendon.
Thank you. So, but there is a limit.
There is a limit.
There is a limit. Thank you. Our next question is from Amy. We're going to switch gears. If you have chemotherapy and diabetes, they often cause neuropathy. Is there anything that can be done to relieve pain and further deterioration?
A good question. Neuropathy can be caused, right, by chemotherapy, as you mentioned. It's frequently caused by diabetes. And patients can have what we call multifactorial nerve symptoms. So the neuropathy also causes numbness and tingling, but you can have neuropathy and carpal tunnel at the same time, and they just compound each other. So one option is to do a cortisone injection into the carpal tunnel to hopefully help with the patient's symptoms. And if the patient gets relief with that, even if it's 50%, but it decreases their neuropathy symptoms in half, and then the symptoms come back, they would benefit from carpal tunnel release. So always, I think, important in patients who have neuropathy, even if it's been brought on by chemotherapy, to assess for a component of carpal tunnel, because that's something that is more easily or readily treatable. If the symptoms are purely from the chemotherapy-induced neuropathy, stopping the medicine when it's appropriate, of course, is helpful, but also there's medical treatment that can help with that, with the neuropathy symptoms. And those include a category of medicine that has gabapentin or Lyrica or something called Elavil, which are not narcotics, but they help to address nerve pain. And that would be something to discuss with your doctor to make sure that there's not a increased risk based on your other medical conditions, but particularly patients who have bad neuropathy pain that keeps them up at night, those medicines can really be very helpful.
And what I understand about those medicines as well, it's not something, a quick fix. It takes some time, right, to get into your system and really get moving. Unlike if you were taking an over-the-counter type medication just to give you a little bit of relief.
Correct. It does. And often the dosing has to be titrated to see what works best for the individual. So yeah, it's not the kind of thing that if you take a few and it doesn't work, you say you're done with that. It would be something that typically you and your doctor would work with over a course of at least a month. Right.
That's to build up. So, because I think it's hard when you're in a lot of pain like that, you can get frustrated that you're starting and those types of drugs, and then you're not really seeing the result right away, because it does take a while.
It does, but hopefully it helps, and if it makes the symptoms better, it's certainly worth it.
Yep, good communication with your physician.
Yes.
Yeah. So and now our next question with Rita, and I'm sorry, we're kind of all over the map here. It's that kind of how the questions come in. She wants to know, so if you get carpal tunnel syndrome during pregnancy, are you more likely then to permanently have it?
Great question. No, the studies show that it's truly primarily associated with increased fluid retention, which causes decreased space for that nerve. It should get better after delivery, and it does not put you at increased risk for carpal tunnel outside of pregnancy.
That's great news.
Yeah, that's something good.
That's a bonus. So next question is from Sue. So when do you decide to get surgery?
Good question. For really any of these conditions, you typically decide to have surgery when the non-operative measures are not working. And so for a trigger finger, that's if it comes back after cortisone injection or after a couple cortisone injections. For arthritis, it's if you have pain on a daily basis, or pain that keeps you from doing what you want to do, or pain that wakes you up at night despite a splint and or a cortisone injection. So to having tried something non-operative is always recommended first. The exception to that for the topics that we talked about would be severe carpal tunnel. So if you have carpal tunnel and you already have some muscle loss, then we strongly recommend going right to doing surgery, because we know it's not going to get better. And the quicker you release the nerve, the less additional muscle loss you will have. So that would be a right to surgery. And in a fracture situation, not all fractures need surgery, but if you have a broken wrist or broken finger and it's displaced or angulated, typically that's a recommendation for surgery.
Sure. Thank you. So Dr. LaPorte, what research is currently underway at Hopkins?
So in the area of hand, a couple of things that are relevant to the topics we talked about tonight would be the alternative treatment for thumb CMC arthritis, being the denervation. And that's appealing because it would be a quicker recovery. It's an all soft tissue surgery. There's no bone work that's done with that. And if it is shown through our studies to have comparable results to the joint replacement, I think that would be very appealing, particularly for younger people who want to get back to activity quicker. And it doesn't burn a bridge. You could always have the joint replacement down the road, but the work that's being done is to look to see, do you get the same result anyway? And then it would be something for people to consider. Looking at more comfortable ways to diagnose carpal tunnel syndrome. I don't know if there got to be people who are on tonight that have had a nerve conduction study. It's very definitive, which is great, but it is also pretty uncomfortable. And so having a non-invasive way to diagnose carpal tunnel, for example, through ultrasound, is a very active area of research. And that some of that is being done at Hopkins as well. And we're studying treatments for the surgery of the ulnar nerve. We're also doing research on best treatment for wrist fractures in patients over 60. So there's a wide variety of people who are over 60, because you can be extremely active and you can be not extremely active. But looking at whether people do the same with or without surgery in that older age group or fragility fracture age group, even though they're not everybody is going to be the same in that group. And that's I think that can be really important down the road, because surgery for a wrist fracture is not a small undertaking. And if the results are comparable, if you do a less invasive form, either with pinning or with even with just casting, that may really change the way we treat these fractures.
Sure. Thank you very much. So what about CRISPR or stem cells for any of these wrist issues?
That's a great question. And there's done a lot of looking at PRP, the plasma reactive protein, or stem cells for thumb CMC arthritis. And there are no studies that are showing that has made a difference, has improved outcomes. However, for tendonitis, particularly tennis elbow, there's some really good studies showing that PRP can be very beneficial. So tennis elbow is a tendonitis at the elbow. Patients typically will have pain if they're trying to lift anything away from their body, like if you're picking up a pot or a pan, and it's pain at the outside part of your elbow. And sometimes patients will have therapy for that, or have a splint, or have a steroid injection. But it tends to be a recurrent or a nuisance problem. And PRP has been shown to be very helpful. And the surgery is not great for that. So that would definitely be an area to consider stem cell treatment.
Great. Dr. LaPorte, thank you very much. It looks like we're running out of time. So I want to take this opportunity to thank Dr. LaPorte very much for all of your time this evening, and thank all of you for following us this evening. And Dr. LaPorte has graciously agreed to respond to any unanswered questions that were asked this evening. So in a couple of weeks, you'll receive an email providing the answers to the questions that we didn't have the opportunity to ask this evening. And in the coming days, the video of tonight's live stream will be available on the A Women's Journey website, hopkinsmedicine.org/women's journey under Conversations That Matter. And if you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/a woman's journey, for information about our forthcoming special program this Saturday, November 13th, and announcements about future conversations and podcasts, all featuring Johns Hopkins physicians and faculty, and brought to you by A Woman's Journey. In the meantime, we hope you find our monthly mail informative and engaging. Have a good night and stay well.
Thank you all.